morning, everyone, and thank you for that introduction, Dawn. And thanks to the organizing committee once again for bringing me back to Bangkok. It's always nice to start the year with a conference in Bangkok. So I've been tasked today to speaking on progress towards the fourth 90, and I hope I do it a bit of justice. So today I'm going to be talking about what defines fourth 90 and really thinking about incorporating the fourth 90 or health-related quality of life in HIV care. And along with that, the challenges that arise and using specifically patient-reported outcome measures, which are becoming increasingly used beyond clinical trials and moving into HIV care. And finally conclude by talking about interventions very broadly as a way to improve health-related quality of care. The WHO Global Health Strategy on HIV, viral hepatitis, and STIs have now recommended for some time now a move towards a holistic, people-centered HIV care approach. And we've heard a lot about this recently. Our care really needs to moving towards making people living with HIV the center of our care. And this focuses essentially on long-term well-being, which incorporates domains such as health-related quality of life, concentration on comorbidities, particularly around mental health, and combating stigma and discrimination. These are various cascades of the HIV continuum care across a number of mainly high-income settings across Asia from the white paper which was released in APAC in 2023. And what we can see across the various HIV treatment cascades are essentially that viral suppression rates across many of these countries are doing exceedingly well, above 90%. And there is a need, not just now and not just after you've achieved viral suppression, but across the continuum of care to look at quality of life and how people actually are doing with their health care. The bar on the right represents the changing demographics of people living with HIV across the Asia Pacific. And this is data from Tehot Light from 8 clinical sites. And the projected estimates for 2025 are that 1 in 3 people living with HIV across Asia Pacific will be more than 50 years old, compared to 2 out of 3 in the Netherlands will be more than 50. People living with HIV will be more than 50 years old. Looking more locally within our setting, this is the age distribution of patients attending the UMMC ID clinic in 2023. Already 35% of our people living with HIV are above the age of 50. And when you project this to 2028, 50% will be over the age of 45. So whether we want to get on board with this, we have no choice but to look at areas, particularly around healthy aging. We also know that there's a high burden of multimorbidity in people living with HIV. We know that premature aging occurs in people living with HIV. And this is data already from more than 10 years ago, showing that there's a high burden of multimorbidity in people living with HIV compared to their HIV negative counterparts. And this occurs on average about 5 to 10 years earlier. Looking at another area which is of importance and a specific focus of the Treat Asia network within the region is mental health and also quality of life in people living with HIV. This is data from the S2D2, also known as Substance Use, Stigma, Depression, and Disability Study, showing that the prevalence of moderate to severe depressive symptoms occurred on about 19% in 864 people across 5 sites, and 62% reported moderate to high risk assist scores to any drug, so substance use, around substance use. And with increasing depression, symptom severity, and substance use risk, there is greater impairment of functional disability and a subsequent impairment of quality of life. This is now moving towards stigma and discrimination, and although we're talking about people living with HIV, it of course incorporates key populations. And this is data from Malaysia showing how our future HIV clinicians, when asked on an online survey what their attitudes were towards people living with HIV versus other key population. And the lowest attitude scores, which reflect the greatest stigma, were highest for people who inject drugs and MSM, and less so for people living with HIV. But this is of concern. And this is something that I've already shown before in other slides. And once again, this is HIV prevention, but it impedes the HIV response and certainly affects quality of life for people living with HIV. PrEP stigma remains at an all-time high, and it complicates HIV responses within countries, particularly Islamic countries like Malaysia. And this was really since January 2023, where the public sector took the bold move. And this is bold, not by national standards, but certainly by Malaysian standards, to scale up PrEP within the public sector. We've been working with them for a very, very long time to do this. And when they took it on board, they took it on board. And you know, a lot of praise deserves to be given to the Ministry of Health people for standing their ground on this, despite the fact that there were many backlashes from religious academics, religious healthcare professionals, and religious leaders. They stood their ground, and also healthcare professionals which are represented in this meeting today, like the likes of Dr. Sadia and Dr. Sheila, primary care providers who are involved in the PrEP Scale-Up program. And so navigating HIV prevention policies around religion can be extremely very difficult in countries like Malaysia and impact on quality of life. So how do you define health-related quality of life? Well, quality of life is simply defined as the general well-being of individuals and societies. Health-related quality of life is a multidimensional concept that includes domains of physical, emotional, mental, and social functioning. And those working in geriatric care are very familiar with these domains of health. So essentially, the fourth 90, or achieving good health-related quality of life, was proposed by UNAIDS for some time now. It's largely been proposed due to increasing number of countries and now area within the Asia-Pacific achieving viral suppression rates of greater than 90%. But once again, acknowledging that viral suppression should never be the end goal of HIV treatment, and looking at how we deliver quality services to people that matter, and promoting wellness rather than survival. But we shouldn't be looking at this only after patients suppress viral load. We should be looking at this across the HIV care continuum, so at the point of diagnosis, on treatment, and as well as when they're virally suppressed. There is enough evidence to date to show that people living with HIV report poorer health-related quality of life outcomes when compared to their HIV-negative counterparts and compared to people with other chronic health conditions. We know it predicts survival, hospital discharge rates, and particularly the physical and mental dimensions of health-related quality of life predict viral rebound. And we know that trying to improve outcomes around health-related quality of life also improve clinical outcomes, adherence, and retention care. So really, we're moving towards a person-centered HIV care. And for those who are interested in this, there's a JIS supplement. I think it was released at IAS last year, if I'm not mistaken, really giving specific examples and why there's a need to concentrate on long-term well-being and health-related quality of life. So what components of health-related quality of life are important for patients? So, of course, treatment and focus on treatment and information needs remain a priority for people living with HIV, but it is not all about their antiretroviral therapy and viral load. Physical components, particularly issues around pain, diarrhea, weight changes. Management of obesity has been also voiced as one of the main concerns around people living with HIV from the UK perspective, particularly as integrase inhibitors get scaled up. Psychological issues and issues around mental health, anxiety and and depression are absolute priorities for people living with HIV. And cognitive issues such as memory and sleep, how they socially function, who they're intimate with, are they alone, and who supports them in the community? Their functional ability and ability to perform activities daily living. And I think we're all very familiar in a HIV clinic that if we do not address the welfare needs, particularly around finances, assistance around medication, really nothing moves from the perspective of the patient. So healthcare-related quality of life is commonly assessed by what we know as patient-reported outcome measures, which reflects patients' perspective on their healthcare experiences, which is more important than what we think they need. It's them telling us what they feel is important to their healthcare. And really, once again, to reiterate, a move away from the standard model of care, which relies on a biomedically driven model and prioritizing antiretroviral treatment, lab results, ability to take treatment, and their problems related to antiretroviral therapy. In the traditional model of care, other concerns such as cognitive impairment, psychological concerns, welfare concerns are peripheral, and they're not really brought up unless the patient specifically brings it up. And so there are problems with that kind of consultations. But there are challenges associated with the fourth 90. So how do we really define it? And how does it apply to different ages, different socioeconomic populations, different regions across the region? When do we measure it? At the point of HIV care, at follow-ups? How often? How does this already impact on a busy HIV clinic? Now, we've mentioned one way of doing it is using patient-reported outcome measurements, but which PROM would be ideally used? And how do you define success? And above all, currently, there's a lack of implementation guidance around this. So just to bring patient-reported outcomes and explain it specifically is a report of the status of a patient's health condition by the patient without really us coming in and interpreting it by a clinician. So it's really addressing, once again, the question of what matters to you, what aspects of healthcare is important to you, i.e. the patient, rather than bringing up the question and saying, what is the matter with you? And there are tools to help us determine what matters to individuals in care. There are many reasons why we should use patient-reported outcome measures in HIV care. It makes care more personalized and holistic. It defines areas which we are not meeting from the patient's perspective. We often are very good as HIV care providers to identify physical needs, but beyond that, we're not so good. We're not general health physicians after all, but we have to be trained, or we're moving towards that, if we haven't already. Routine use of PROMs within healthcare identify problems and concerns that matter to patients, such as mental, sexual health, and at a service level, it helps improve service quality. It also increases satisfaction in patients. Patients feel heard. We're already used to PROMs being used in clinical trials. So if you look at any clinical trials, a lot of the secondary endpoints are patient-reported outcome measures, such as treatment satisfaction, treatment preference. A recommendation here is to take it out of clinical trials and move it towards clinical practice. We already also have PROMs available for single-dimension outcomes, such as depression stigma. But really, there's no current brief centered PROM that reflects a range of outcomes that are important to people living with HIV to drive and evaluate clinical care. Now, very quickly, there's two types of PROMs. There's generic PROMs and there's HIV-specific PROMs. And this is an example of a generic PROM, which is not disease-specific. It addresses very broad aspects of quality of life, is extremely short, and in this case is the European Quality of Life 5-dimension. It assesses the physical and mental dimensions of mobility, self-care, activities of daily living, pain and discomfort, and that very brief anxiety and depression. Very easy to do. And there's no clear guidance, unfortunately, at this stage on which PROM is best. Within HIV, there's 115 HIV-specific patient-reported outcome measures, ranging from stigma, perception of body shape, treatment experience, adherence, side effects. And there are newer instruments developed by people who are particularly interested in this area within the UK that reflect and bring the voices of people living with HIV into the development of these tools. And for example, this is a positive outcomes tool which is in the UK. But currently there's an absence of gold standard, and looking at the systematic review of instruments used specifically to address health-related quality of life in people living with HIV, the most common one within the HIV-specific PROM is the WHO Quality of Life BREF, and the generic one is the SF36. And all these domains are unique to specific HIV instruments around worries around death, stigma, and HIV disclosure. These are creeping into guidelines. This is within the European AIDS Clinical Society guidelines, which is one of the more comprehensive guidelines around comorbidities and comorbidities management. And what they have suggested is that we use it to assess symptoms and quality of life. We should be using it annually and using standard validated questionnaires and instruments. The choice largely depends on us and what is required locally. and should be guided by persons living with HIV within that geographical location. So for example, if substance use is a particular problem within that clinic or that population, then this should be addressed. This is a problem that should be addressed within those instruments. And as mentioned, we already use a number of PROMs in clinical trials. The Positive Voices survey, which was actually recently released a couple of days ago, looked at the health-related quality of life and the voices of people living with HIV in the UK using the instrument European Quality of Life 5 Dimensions, so that generic PROM. This was repeated from 2017, so this is about 7 years, no, is it 7? 2000, about 5-6 years later, and compared to the initial survey results in 2017. Essentially, the survey results were the same compared to 2017, but what essentially was different and remained different was that differences continued to be observed in people living with HIV in terms of the anxiety and depression scores compared to that of the general population. And there, just to also mention, apart from patient-reported outcome measures, there's also increasing use of patient-reported experience measures looking across a number of outcomes. In this case, it was across domains such as the clinic provides enough information around my HIV, the patients feel supported to self-manage their HIV, they're involved in decision-making around the HIV, the staff listen to them. So this is essentially what matters not just in HIV clinical care, but in clinical care across other specialties as well. And these are experiences from the UK. Overall, the UK services are doing extremely well. They exceed more than 95% across the ranges of PREMs. And something that we really should look at our own clinics to try and improve the services that we produce and deliver. So moving on to interventions to improve health-related quality of life. Of course, HIV control predominates, but that's not the only intervention. We need to think about target and supported physical activity, particularly in people aging with HIV, mental health, stigma, and also direct patients to tell them how to manage their symptoms. There is a need as we progress with an aging HIV population to integrate clinics around both mental health and aging and focusing on multimorbidity, and within the older people living with HIV, frailty. And there is some guidance. Now, this is a consensus statement from about 44 HIV experts, along with people living HIV, clinicians, and researchers, who convened essentially to address how health systems can advance the long-term well-being of people living with HIV. And this involved basically 4 key areas. Firstly, prevention, screening, management of comorbidities. So if clinics are not already doing this, they really need to do this. We need to look at and pilot models, frameworks around frailty, aging, healthy aging, not just aging, but how people age in a healthy way, and functional ability. We need to reduce barriers for vulnerable groups. We need to collect and document data on health-related quality of life. And we need to continue to develop interventions to decrease stigma and discrimination within healthcare settings. It's important that we include management of comorbidities within our own national HIV treatment guidelines, specific to people living with HIV, but also involving people living with HIV in that decision-making with regular updates. And this is an example from WEACS. The white paper, which was released as part of the HIV care continuum in APAC last year, also addressed specific interventions within the Asian context of how to improve quality of life. Firstly, you need to conceptualize it, and you need to think about monitoring quality of life. Areas that should prioritize essentially, once again, are stigma, aging, comorbidities, and mental health. And integration of services. And this is also a major focus of area of research within our region. And a lot of countries are looking to implementation research to see how best we can integrate comorbidity management, whether it's mental health or aging related to HIV within the region. You can't talk about quality of life without really emphasizing the importance of U equals to U. Healthcare professionals bringing up proactively and discussing U equals to U with their patients is associated with a positive and significant outcome across a range of health outcomes, be it mental health, sexual health, viral suppression, and optimal overall health. And just to maybe reiterate the importance of this, as advocated by Prapan Panupak in his lecture at the beginning of this conference, it is so important to bring this up proactively and using language that really matter. So for a long time, even a lot of healthcare professionals were very reluctant to use the term zero risk, and a lot of, and myself included, we use terms like negligible risk, low risk. But the risk that comes with transmission of HIV in the setting of a patient, from a patient with an undetectable viral load, is really zero. And this is supported by many research studies, which include 125,000 condomless sexual acts. So the evidence behind that is strong. And providing the evidence behind that is also important when patients themselves are sometimes reluctant to believe when you tell them there is zero risk around HIV transmission. And this also is, the use of language around this is also reflected, and I ask you to read this, is the importance of person-first language, an introduction to the People First Charter by a colleague in HIV medicine of this year. Now, moving on to stigma and interventions to reduce healthcare. Stigma is a major focus within some of the work that my team in UMMC do, particularly around reducing clinician stigma. And what I've shown on the left side essentially is not to essentially show my face there, but is how you can communicate some of these messages. And this was a topic of discussion around World AIDS Day 2021, of which my colleague Puili moderated a very successful session, of the question being around, should healthcare workers with HIV be allowed to work? And this was following a release of earlier guidelines, much outdated, but at least they were there, of guidelines around how healthcare workers, or permissiveness of healthcare workers from the Malaysian Medical Council being allowed to work if they had HIV in the setting of an undetectable viral load. What was obvious from discussions around this is that a lot of people, healthcare professionals, are not aware of U equals U. There's no surprise there. But when they're informed, they generally get on board, and they're generally supportive of that. And it's important to include within the healthcare setting certain people. So who's depicted there is the head of surgery, the head of occupational health, and also allied healthcare professionals, such as the head of nursing, because they are important in that decision making to move that from a higher national level to a hospital level. And as I said, a lot of people on board. And this can also be used. The fact that people living with HIV who are healthcare workers are now given the right to work in healthcare settings should therefore prevent workplace discrimination in any other area of work, particularly if they're allowed to work in exposure-prone procedures, such as in surgical areas. And some of the work that Malaysian AIDS Council and Malaysian AIDS Foundation have done recently this year to combat stigma in people living with HIV, there needs to be reporting mechanisms in place. And without those reports, so that starts the process. There is workplace discrimination, unfortunately, continues to exist everywhere, but particularly in Malaysia. I'm not highlighting this as bad practices in Malaysia, but sometimes we highlight it to improve things. One of the problems was that there was no formal mechanism, and now we do have a formal mechanism. And for my Malaysian colleagues in the audience, Malaysian AIDS Council has a MAC Care, which is an online communication channel for our community to report any specific issues of discrimination, and MAC will deal with it on an individual basis. What was particularly exciting is at our Red Ribbon Gala this year, where we raise money, particularly for second-line treatment people living with HIV. We did not have any legislation to protect people living with HIV from workplace discrimination. And a lot of this work started before COVID and got stalled during COVID. And what essentially happened was that you need two acts. You need the Employment Act and the Industrial Relations Act to come into effect in order to protect people. And so the political secretary was invited to the Prime Minister, and he was given a speech in support of this. And once they're on board at a higher prime ministerial level, this then subsequently moves into action. And it's knowing how to get the right people in that decision-making process to move things and agendas forward. And then we have treatment. And once again, so I use this as an example because there's a point of frustration for medical healthcare practitioners in Malaysia. And I use this because I'm most familiar with the example around what happens locally. Unfortunately, in Malaysia, we still use a lot of efavirenz as first-line antiretroviral therapy. This is not because we want to, but because we have very little choice. Now, we have had originated dolutegravir for some time, but we've not had access to generic dolutegravir until November of 2020. And this was largely because of an expanded voluntary licensing agreement, which was only applicable to upper middle income countries, 4 upper middle income countries. And I'm told this is the first time this expanded voluntary licensing agreement was done. Behind that, there were a lot of, unfortunately, it was not hugely transparent. And what essentially materialized, and the frustrations around that, was that one, generic dolutegravir was priced at least 12 to 15 times more than it was in Thailand in comparison. And secondly, there was restriction on access to private practitioners, which is also, why should it be the case? And some of the ongoing work that we're doing is really to negotiate that ongoing process, but it looks like those, we're stumbling with those discussions. And it may be that at some point a compulsory license will be issued if those negotiations are not brought, or we do not agree to those negotiations. And that would be very unfortunate if that happens. And how do we then talk about long-acting antiretroviral therapy, which is a highly exciting area in the era of HIV treatment, and the huge opportunities that come with it in terms of less frequent dosing, increased choice, protection of health privacy, and removal of that daily reminder of HIV with oral treatment. But once again, it's history repeating itself, and all this impacts on the quality of life of people living with HIV within our region. We can see that this is countries which have approved cabotegravir and rilpivirine for treatment within our Asia-Pacific setting has largely been within the high-income world, and therefore, once again, exacerbating inequities and inequalities. Finally, to conclude, we need integrated models of care. A major priority to improve people living with HIV is to concentrate our efforts on various models of care around HIV and aging. And whether those models involve bringing your geriatrician to the clinic or multidisciplinary meetings involving the geriatrician on a regular basis is determined by what works within your setting. And as people get older and a bit more frailer, it's important to concentrate on multi-morbidities and extending assessments, including frailty. And for those of you who attended a very easy to understand session on clinical frailty by my colleague, Dr. Puili Wong, has made a convincing case that it is very easy to screen frailty within the clinical setting using the clinical frailty score and by asking just 3 questions. So within our own setting, we have looked at incorporating multidisciplinary team meetings, incorporating various different specialities, which we feel it's important to address patients who have multi-morbidities or geriatric syndromes. These are occurring on a monthly basis, but the hope is that this will continue to increase more often. And looking at different models of care and looking at nurses and task shifting to nurses and increasing what they can do in terms of screening for depression, mental health, cognitive impairment within the clinical setting. So I'm just going to conclude. Essentially, I feel it is time to redefine and objectively measure the success of HIV care in the era of high suppression rates on antiretroviral therapy. We can start doing this by using PROMs. We don't need to wait for a gold standard. We can already start using this and really thinking about what people think about the services and the healthcare that they experience. And 4 key areas which, to advance the long-term health and well-being in people living with HIV, just to summarize, are prevention, treatment, management of comorbidities, healthy aging, in cooperation of patient-reported outcomes, and combating stigma and discrimination. Thank you very much, and I'd like to acknowledge the couple of people on the slide to help me with slides. Thank you very much.